Today we got the chance to visit Dr. Kashif Baig, a renowned ophthalmologist of the Ottawa area. From cataract surgeries to a facility tour, make sure to stick around as we dive into a day in the life of an ophthalmologist.
And we have the entire floor of our surgery center. Front desk room over here. We go through this part over here. This is where our patients come. Patients get assessed in this room here, and some may get the laser done. So this laser actually does all the incisions and cutting of the cataract before the patient comes into the OR. And the OR is here. So this is the OR setup. So we have here the patient lies on the bed. This is a surgical microscope. We're able to see things in more magnification. That's the machine called the phaco multiplication machine, and that machine basically helps to break up the cataract. This machine actually helps us to do some intraoperative measurements, and that machine, that screen, basically tells us what the patient's demographics, the eye, and what the name is. So we got the proper patient, proper eye, proper surgery going on. This is the first of two ORs. These are all the lenses that we use to implant in the eye. The second OR is over here. This is one of our fun rooms. This is what's called a Diagnostic Center. And here we do all the measurements of person's eye. So we have various machines that so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 machines here. That all they do is they measure the front part of the eye. And so this gives us all the information we need so that we can plan out surgical procedures and offer options to patients. Let's go down here. We have another laser in this room. This is a laser that's often used after cataract surgery. These are our counseling rooms. So patients, when they come and they want to get, after I see them, they come to a counseling room to get the information about, everything from pricing to scheduling to the logistics of doing the surgery. And that person becomes their point person. If they have any questions, they will go to that person to ask and get more information. This is a typical, what we call lane, where we work up our patients. We have what's called a slit lamp microscope. This gives us high mag views of the eye. We have our screens to see the various imaging so we can kind of counsel patients accordingly. We have several of these lanes. This here is a machine that is what's called an adjustable lens machine. So what this machine does is, as what you were seeing earlier, where most lenses get put into the eye, they're fixed lenses. So whatever the prescription, where the power is, that's what the power is. With these adjustable lenses, what we do is we put the lens in, and then we can modify the power of the lens post-operatively in a non-surgical way. The way it's done, we shine a certain frequency of wavelength of light into the eye, and that actually changes the polymers in the lens to change the prescription, so to speak. So you can adjust this, and it's called a light adjustable lens, to be able to adjust the power to where we want it to be. This brings a bit more precision into our surgeries. And here's another fun room over here. This is our laser suite. So we have here what's called a femtosecond laser. This is called SMILE. This is what's called an optically guided excimer laser, a wavefront guided excimer laser, and another femtosecond laser. So these 5, we have 4 in this room, and then another laser which we saw there. We have 5 lasers to be able to do the surgery that we want to do, and we can really customize it to what a person needs. And so person A may need a certain machine, person B may need something entirely different. So with that, we have all the options, all we call lens-based and cornea-based options to be able to give whatever kind of treatments that are needed. case of a cataract procedure, and it was a gentleman who had some fairly dense cataract changes, not seeing so well for a few years, and so we did surgery. It took about 10 minutes, and we put a special lens for him, and he's out now and seeing better. And so this is something that we do on a fairly routine basis, cataract surgery. And the surgery is done across the province. It's done at private centers, it's done at university centers, it's done at various clinics around the province. It's fairly satisfying surgery as well. You know, you're able to transform a patient who's not seeing well to someone who is able to see well, and it does actually make a big change in their lifestyle. So the patient was brought in, and the surgery went uneventful. We're able to take out the cataract and put the new lens in. He's going to be on drops for a little while. You know, it's going to be, these drops are to prevent infection, anti-inflammatory drops as well to help with the healing. And within a few days to a few weeks, he should be kind of stable. So in World War II, there were these British Spitfire planes, and they were used, you know, in dog fights in the air and stuff. But what happened is that, you know, sometimes their canopy would, you know, break, or there'd be a bullet that goes through, and part of that canopy would get embedded in the pilot's face. All right, and so what they found was some pieces actually went into the eye, different places. They were actually inert. So this is a canopy, transparent canopy. So well, maybe we can make a lens out of this material. So they kind of made the lens from the canopy findings, and as you know, evolution happened over many decades. We now use an inert piece of plastic. That is when the cataract comes out, the new lens goes in. The new lens will now provide the optics that are needed for the eye to see. And it all came about from this experience, from these canopies that were bursting onto pilots' faces, and they were found to be inert, not causing a reaction. So that's how we end up using intraocular lenses. It's basically, for this kind of surgery, you actually need ear, eye, hand, and foot coordination. I'm using my 2 ears to listen to the machine's tongue, and I'm using that audio feedback to influence what my hands are doing and what my pedals are doing. So one pedal, left foot is doing one thing, the right foot is doing something else. Each hand is doing something. Both eyes are looking through, and then both ears are listening to what's going on. So that kind of eye, ear, hand, foot coordination allows us to do that surgery. And you're going to feel a little more water here. This next patient is a gentleman who actually is seeing quite poorly, to the point where he's not able to drive, so he lost his driver's license. And so what we're going to do now is go ahead and take out his cataract, it's fairly dense, and put in a new intraocular lens, which will reestablish his vision and clarity so that he can regain his driver's license. It's a patient who has a pretty healthy overall history, and so we're going to be taking out the cataract and hopefully making a big change in his life. He has certain measurements that we've done, so we try to personalize what we can do for each patient, and that involves having several measurements that are being done, 3 to 4 different kinds of measurements, and each of these measurements tells us a little bit about the eye in a different way. And that way we put the pieces of information all together and figure out what is the most appropriate kind of customized solution for this individual, and for this in particular eyeball sometimes even. And so with that, because there's so many different kinds, all these lenses are here, and so we have so many different varieties and variations and permutations that we can do. We try to personalize the lens selection to what the patient is requiring for their lifestyle, requiring for their anatomy, their physiology, and their numbers. From 6 to 10 microns. So our movements that we're making, we have to look down a little bit. There we go. Okay. The movements we're making have to be with knowing that there's only 6 microns of tissue between where you want to be and where you don't want to be. So your movements have to be very calculated and precise. Where basically fractions of a millimeter are recorded. So this next patient we're doing, we're actually operating on his good eye. So his other eye, the not so well-seeing eye, has been poor seeing eye since he had an injury, remote injury, and so that one eye is kind of really out of commission. It's not really contributing to his vision. And so we are now operating on his good eye. So the poor eye is not, you can barely see the big E on the charts. And so the other eye has got a cataract. So now we have to get cataract to have this well-seeing eye. Of course, this means we have to always be, we're always cautious, but this means we're operating on the only eye of a patient. So we always think about, risks that can come about. Risks include infection, inflammation, retinal tears, retinal detachments, increased pressure in the eye. So these are things we always watch for. And so we do full counseling and kind of for the consenting process when we do the surgery. So we're going to go ahead and do the surgery, take the cataract out, put new optics in. The optics that we use, there's so many different kinds of lenses that we have. So we chose a lens that's going to give you really pure optics because this eye is the only seeing eye, and we want that optics to give really good information to the brain, crisp optics so you can see well. He's going to be more dependent on glasses than some other patients, but this is going to be perhaps the best fit for his situation. So we just finished with this gentleman. The surgery proved to be a little bit more challenging because his pupil was quite constricted, which means I have a smaller window to work through. Because the cataract actually goes out to about 12, 13, maybe sometimes even 14 millimeters, but we only had a view of, let's say, 5 millimeters, 4.5, 5 millimeters. So that made opening the capsule, opening the rexis, which is opening the capsule a little bit more difficult. And we will get the cataract scooped out, but you have to kind of always see how it is because a lot of stuff is hidden from your view. Also, you want to keep your machine, what's called the phaco tip, right in the center. Because if you kind of venture a little bit away, and remember now you've got a little bit less real estate to work out of, you can snare iris and chew it up. And so you can actually chew up iris, so you have to be very careful where your tip is. Kind of feed with your other hand the pieces to that tip so that you can remove them all. And the other thing that was made a little bit challenging is the patient had what's called a toric lens. That means that there's some astigmatism. Astigmatism basically is a situation where the cornea, instead of being more like a golf ball, is more like an egg shape. And so we can put a toric lens to help counter that astigmatism. The marks on the lens where it tells us which orientation are on the periphery. So in this case, because the pupil was smaller, I couldn't really see the marks, so I had to kind of move the lens around to see exactly, to make sure that the alignment of this toric lens, because the alignment of the lens is very important. It tells you what axis, the lens should be at, and we want to make sure it's right at that axis. So luckily at the end, it was right at the axis, all the cataract was removed, and everything went very uneventfully, which is I'm happy because it is his good eye. And this new lens will allow you to see well for distance. A little bit of what we call distant intermediate, but anything kind of like within here, you'll need to wear glasses for.
Okay, but you don't, you seem not really strong glasses, eh?
No, not very strong. You can get them at the drugstore if you wanted. Something very simple. We're also going to help to correct your astigmatism. Okay, so you have a little bit of, so we're going to decrease that to make the vision a little bit better quality.
Okay.
Okay, so for that I'm going to make a little mark each side to get you ready for the procedure. I'm going to have you look up for me. Lots of drops for you to use, not a drop. 1, 2, 3. And same thing here. 1, 2, and 3. There you go. Here's a tissue for you, another tissue. You go in gently, wipe your eye, and I'm going to get that mark done. I want to just let you know that we're getting both eyes done for distance. So that means we're going to take the cataract out of each eye and we'll put a new lens in. That new lens that goes in will help you see well for distance. They're actually within the choroid, right over here. So what happens when you have, so the reason why we had to wait for her was because her systolic blood pressure was 230. So usually it's like 120.
22.
It's way high. So if you make an incision, remember there's a pressurized chamber here, right? If you make an incision and the pressure inside the blood vessel is 220 instead of 120, at least when the eye is formed, you have the pressure of the eye, like the contents kind of pushing back on it. So if you make an incision, the pressure goes to zero. What happens to the intravascular pressure?
What was